And everybody, this is Kevin Werling here at Envision New Mexico. Just want to let you know we are going to record the session for those who can't attend. So we'll be sharing that with them. So it's not a closed session, so just so you know. And we have started recording. So who else do we have on the line?
So we have Cynthia, Elena, and Kathy, and Perfina is here also, it looks like. So all of the UNMMG billing folks are here.
Can you guys introduce, this is Kirsten Bennett, working with Veronica on this FRONTERAS initiative. I'm the PI. Could you tell us what each of you does, as part of this, as part of the introduction? Because I think that's going to be especially important for the people who can't attend that we're recording this for. So when they go back and listen, if there's a specific question, that we know who to direct them to.
Okay.
As opposed to maybe CCing everybody or getting a hold of Veronica.
Sure. My name is Kathy Jaramillo, and I'm the manager for UNM Medical Group AR and Denial.
My name is Elena Luisena. I'm the director for the medical group AR and Denials, and it does include our what we call billing. So we do the charge entry.
Yeah.
Hi, this is Perfina. I'm the charge entry specialist, so I will be receiving your charge ticket.
And Cynthia just stepped out, but it's Cynthia Glass, and she is the supervisor for AR and Denials and also for charge entry.
Okay. Do you want to just go around the room here and introduce everyone so that our group here?
Sure. I'm Veronica Duffy. I met you all a couple of days ago, I guess it was. But I work for the Center for Telehealth, and for this FRONTERAS grant, I've been helping them mostly with the revenue cycle piece.
I'm Janine. I'm the FRONTERAS coordinator. I'm scheduling the appointments and things like that, and entering into our chart patients and stuff like that.
My name is Maya Trujillo. I'm a quality improvement specialist with Envision New Mexico.
Yeah, I'm Jane Beckler. I'm a nurse practitioner. I'm one of the clinicians who will work seeing young people through the FRONTERAS grant.
And Kevin Werling, systems analyst here at Envision New Mexico, and part of the technical support team.
So you guys can go ahead and get started. Veronica, if you want to go ahead and kind of lead us through your agenda. And then if we have questions at the end, I know that Maya and I have been getting questions from some of our sites. So at the end, we'll just kind of throw those out if they're not answered. Right?
Okay. So just basically to give everybody an overview of how the billing is going to work, UNM is going to be billing for the UNM consults. So we're the site where the specialists will be. The site where the patients are, that's the originating site. So in most cases, we'll bill for the professional fee, and the originating site, the school-based health centers, will bill for the originating site facility fee, excuse me. And of course, there are exceptions. There's going to be provider-to-provider case consultations. So we'll talk about that a little bit more later on in the meeting. When a student sees two providers in the same day, they may see what's the word? A provider at the school-based health center, and then they'll see a specialist via telehealth. Those are special cases, but we can bill for both of those separately. And then we're going to be talking about some of the different codes, which are health risk assessment codes, and then we also have some group provider codes that we'll talk about more in detail. But that's just a simple overview of how these telehealth billings is going to work. And I did submit a copy of the telehealth charge ticket that we've created for the FRONTERAS group. And so this is what's going to be done on the UNM side, obviously, so this won't apply to the school-based health centers, but it may be helpful to see what we're going to do on our end. So with all of this telehealth charge ticket, the modifiers which indicate that it's a telehealth consult, those are indicated next to every single procedure code. And we're also using the place of service 02, which is a newly established place of service code. This telehealth charge ticket has that as well. So it has built-in TES edits to just ensure that everything is coded properly for telehealth. So that's the overview. I don't know if there's any questions from either of you on billing on the UNM side at this point.
So you said the place of service O2, we don't need to, if we just use this, that this charge ticket will pick that up. We don't have to add it anywhere?
Correct. It's it says location 73 telehealth, sort of near, it's in the gray box.
Okay.
Yeah,
okay.
so it's
I
already
didn't have
there.
it in
So
color.
it's got backup edits in
Okay.
there just to ensure that everything's coded correctly.
Okay. And then I see you have these other codes on the agenda, so I'll ask those questions when we get down
Yes,
there.
yes.
Okay.
And then for the school-based health center, I don't know if anyone from the UNMMG side can chime in on this, but they'll just be using the HCPCS code Q3014. This is to bill the originating site facility fee. And if anybody is curious, the payment amount for this code is 80% of the lesser of the actual charge, or $25.40. But that's basically for the originating site facility fee.
So if you guys could clarify, because I noticed we've got a couple of our school-based health center
Great.
clinicians on. I noticed Tammy Armitage from Lovington, and she's the clinic manager. Where does that go? I mean, in other words, where would they put that in their billing side? I don't know if anybody has that answer, but I mean, that would be a question if I were billing for that. Does it go at the end of their encounter? Is it an extra? Is it?
Do any of you at UNMMG happen to know the answer to that?
Well, this is Alana. We were just discussing that, and I'm wondering, so the medical group is going to be billing for the facility fee, or are you going to be utilizing the hospital billing?
No, the facility fee won't go through UNMMG, but generally speaking, do you know the answer to that question?
No, I'm sorry. Yeah, you would have to get with the hospital that's going to be billing that and how they're going to be wanting it and how they're going to be receiving it and entering that.
So Tammy, I see that you're on, if you want to maybe chime in about where you might put that facility code, the facility fee code. Maybe you know already. I just want to make sure, since we've got all these people on, that we're clear about where you would put that in your billing after a visit.
And Tammy, I can see that you're not on audio. So if you can't join that. Oh, go ahead.
I'm sorry. I can hear you fine, but it's on my phone.
Understood. Okay, I see it now. Go ahead.
So Tammy, do you have any questions about where you would put your originating site fee? Or are you guys clear where that goes? Or if you just want to say that out loud, maybe for other school-based health centers that maybe don't have as much experience as you do?
I'm sorry, I was a little bit late joining. Do you mean, will you shut that door for me? Do you mean the originating site would be the school-based health clinic? However, our billing department out of our main office, which is actually the hospital side, is the one who would do the billing. So I'm sorry, I may not understand what you mean specifically by originating site facility.
So I just want to make sure that you all are able to bill for your facility fee. So in other words, in a telehealth environment, your clinic is the originating site. Just like you would, bill, say for example, it basically covers the work of your front office folks, the front of the house. So the person who does the registration, your MAs and nurses who do the triage, and your telepresenter. So we just want to make sure that you all are comfortable with using this Q code for that originating fee for telehealth.
Okay, I haven't had to use it before, and this is my first time to actually see what the code is. So I had asked one of my billers to join with me, but I don't think Carlene was able to get on today. So I'm going to take this information back with me to make sure that there shouldn't be any problems. I don't believe that there is.
Okay. And I'm sure we're going to find out the first time we try to do it.
Yeah, yeah.
We're just trying to minimize the number of surprises that we have the first go around.
Okay, and
Did you want to also just say out loud, since you joined late, what the actual amount is? Just say that again.
oh, sure. So the originating site facility fee, the payment amount is 80% of the lesser of the actual charge, or $25.40. And Tammy, what school-based health center are you from?
I'm from Lovington Student Health Center in Lovington, New Mexico. What did you tell me the charge was? The 25 what?
$25.40. That is the originating site facility fee payment amount.
I mean, if she charges, if for some reason there's a charge more than that, they pay 80%, but otherwise they pay 25.40. Is that? I'm not understanding that.
80% of the lesser of the actual charge. What does that mean? Or $25.40.
So my guess is if you have, I'm just making this up, but you hosted the billing people, does that mean if there's some kind of negotiated charge for a facility fee, that using this telehealth code, you can bill 80% of that normally established or previously established, but if there isn't one, then it's $25?
Okay, got it.
I don't know. The billing people are on the line. Don't listen to me. I have no idea what I'm talking about.
I guess
it would be 80% of lesser. So if you bill, so I think the most we can get is the 25.40. So if 80% of the charge is than 25.40, then they would pay that. Does that make sense?
Yeah.
Somebody said something, so I didn't hear everything you said. But did you say 80%? If the 80% is more than 25.40, the max they're going to pay is 25.40. Is that what you said?
That's exactly right. So if 80% of the charge is less than 25.40, let's say it's 23.30, then they're going to pay the 23.30.
Okay.
I see.
Still better than the $12 I thought.
Yeah, double almost. Okay. So are we ready to move on, or do we have any more questions on that?
We have one more question. Can you tell us where the patients will be seen?
At the school-based health centers.
Is it all around New Mexico or only the 4 listed on this charge ticket?
Only the 4 listed on the charge ticket.
Okay.
Okay, billing for case consultations. So what we really needed was a UNMMG coder, but they weren't available. So, but we did get some of this information from them before. So let's see, this is regarding, I'm going to talk about medical team conference codes. These are the codes 99366, 99367, and 99368. So for these codes, there has to be at least 3 qualified health professionals consulting on a patient. Let me see. The provider would need to be sure to document their time during these conferences, present, and each professional's contribution to the conference. Again, there has to be a minimum of 3 qualified health professionals, all from different specialties, and they must have provided direct care to the patient within the last 60 days. So these aren't necessarily considered provider-to-provider consults. These are team conferences.
Okay.
And what
But for our
has to occur?
purposes.
Sorry.
Go ahead.
Sorry, just a question from the medical group. Shouldn't those codes be on our charge ticket as well?
Are these numbers not on the charge ticket?
We can't find it.
Yeah.
Okay, we'll add those on. I'll
Thank
add
you.
those on as soon as I get back. Thank you for noticing that. This was from May.
The things we find out as we move along.
Yeah, I know. So much. Okay. And then I wonder if we have.
So can you say those things again out loud? So
Yes.
you're going to add those 3 codes.
Yes.
And who has to document the time of each? And who documents who participated? and who documents that they were seen by somebody at the school-based health center within the last 60 days in terms of face-to-face. Does that go in our note from the UNM side?
Right.
Or does it have to be in all 3 chart notes of all 3 providers?
It almost looks like all 3 of them. So this is a copy from the CPT code book. It says physicians or other qualified healthcare professionals who may report evaluation and management services should report their time spent in a team conference with the patient and or family present using evaluation and management codes. Time as the key controlling factor for code selection when counseling and or coordination of care dominates the service. So she gave an example. I spent more than 50% of this 15-minute visit in counseling and coordination of care. So it looks like all of them.
So if you modify the charge ticket, then are we going to have time allotments down here like we have up here? Or would we also do, in other words, say if it's an established patient and you're level 3, I'm guessing maybe, and then you would choose that, but then you would also say down here, or are these 2 separate? I guess I'm confused about how we would use the charge ticket for that.
And then this is the one I do want to add that I believe these are going to be coder reviews, so you would want to document it in the documentation also, but you'd want to confirm that with Cassandra and Jackie.
Okay. I'm looking at the codes specifically, each code, and they're saying 30 minutes or more for those 2. So for 99366 and 99367, those are 30 minutes or more. 99368, participation by non-physician qualified healthcare professional, and there's no time noted on that one. So I'll have to investigate this further with somebody at coding. So you wanted to know if there's time slots and also patient or new patient versus established.
Right. So if you're going to add those codes onto our billing sheet, is there going to be a box like there is up at the top so that we choose the right one?
Okay.
I just want to make sure we don't make a mistake.
Okay.
And then potentially that would have to be shared with our school-based health center providers, because if they're the other 2 people and we're 2 people here and 1 person there, or 1 person here and 2 people there, they would need the same little cheat sheet, in terms of what they would look for to bill.
Okay.
So this would be a scenario where a school-based health center clinician would present a patient and say on this end there would be at least 2 of us. You have to have 3 clinicians. Mm-hmm. So maybe pediatric overweight, pediatric diabetes, plus nutrition, plus there.
Or it could be that maybe they've got their behavioral health provider, their nurse practitioner, and you on this end.
Oh,
because all of those sites have behavioral health providers, and I can see, especially some of our sites that have started talking about overweight management, it would be very appropriate that their behavioral health person might be involved in that.
Okay.
Is that basically what we're talking about?
I believe so.
Okay.
I believe, what you're saying is accurate. And then obviously, or maybe not obviously, but provider-to-provider consultations, that would be using the 99241 through the 99245 codes.
Yeah. This one.
Uh-huh.
Okay.
Yeah. And those we are currently using for telehealth, and those have been successful for us. We see those on reimbursement, so.
So those are the case consults?
Yes.
Okay. So these others, just to help me and also to impact the quality of our recording here. So all the 99241 through 245 are case consultation, provider to provider, with documentation in our chart. The ones that we're talking about adding are the more than 1 provider in 1 visit.
Mm-hmm.
Okay.
And
so
I don't believe. I'm sorry. Go ahead.
So the majority of the ones that we will most likely use, unless we're using multiple people, are the ones she just talked about, the 241 through the 245.
Correct. Yes.
That and then the actual direct service ones.
Right.
And the originating fee. So if we look at the 4 avenues for billing in Fronteras, we've got the originating site fee, we've got the provider-to-provider case consult, and we've got the direct service. Those are probably our 3 most commonly used, but then we also have this option if we have more than one provider in one day.
Where's the direct service code?
Those are the top listed, the new patient and established patient. So those are 99201 through 99215. So that's where the patient will be present.
Okay, so are we charging 3 different codes usually? 2 to 3 different codes?
So on the school-based health center side, the ones that you'd be using are either the case consultation ones for your provider, the 99241 through 45. Oh, and always, if the patient's present, the first code we talked about, which is the originating site facility fee.
Okay.
We would be on our side, the UNM side, billing for direct service because it's our subspecialists who'd be seeing the child in the direct service environment. In other words, your telepresenter presents the child after having done the triage, and then our provider sees that child or that family together via telehealth. That's the direct service piece. So you guys wouldn't be billing for that. That's why the originating site fee is so important, because it allows you to still bill for the time that you all spend getting the patient ready to be seen by any provider. Just like you would if it were Tammy, if it were Holly, and your behavioral health provider seeing the child face-to-face in the clinic. You're still doing that upfront work for the provider via telehealth.
Okay, so we usually then won't charge the direct service fee, right? You guys would.
Correct.
Okay.
But the other one,
consultation.
yes, the consultation fee. You guys would have to bill that on your side too, as well as us having to bill it on our side. Just because we would want to make sure that your provider got credit for the time they were spending in that case consultation, and that's why we still want to go through the registration process of referring the patient, making sure that that patient gets entered into PowerChart so that the provider on our side can actually document the time they spent in case consultation on that child.
Okay, so the only time we're going to charge for the case consultation is when there's 3 people there, 3 qualifying people. Is that right?
No, so the consultations, the 99241 through 99245, those you can just have provider to provider. These other ones that I'm talking about, where are they now? Here we're at 99366, 99367, 99368. Those are the ones that will require at least 3 providers.
Okay, so will we always be doing a provider to provider? I thought that's what the referral paperwork was for. Are we doing something different where she has to sit down and visit with her every time, or is that only if we see necessary?
Right, it's only if you see necessary. So what we look at is what is it that our providers can offer your group of clinicians. Sometimes it might be that your behavioral health provider or Holly or your nurse just wants to talk with one of our providers about how to take care of a patient. In other words, they don't actually want us to do a direct service visit. They just want help. And so that's where the 241 through the 245 come in. If you guys just want to talk to a provider. But we still want you to do the referral using our referral pathway, because we want to be able to document that conversation and all the information in our chart for a couple of reasons. One, so that we can have the backup for and the justification for the billing. Secondly, you guys then would also have the ability in our in-page accounts to go in and have that read-only access to that visit. So it's just structuring the documentation such that we can justify the billing.
Okay, so but we would never bill the direct service codes. Y'all, the telehealth provider would do that.
Correct.
Okay.
I mean, you guys are using direct service codes that are slightly different when you see your patients anyway. Right. But we wouldn't be involved in that. You don't have to. If we're seeing the patient actually via telehealth, we would be the only ones billing the direct service codes.
Okay, I just wanted to make sure because it's on the sheet, and I just want to make sure how to use it.
And this sheet is actually just for the reference for our conversation today. This is our charge ticket for the UNM providers, but we wanted to have it so that you could see what we are going to be doing on our end, and also what you would need on your end. So the ones I think that are going to be really important are the 241 through 245, because you would be using that. So that's one of the things, Tammy, you could follow up with your coders and make sure that they're clear about that. And then it looks like we also are going to need to clarify the 99366 through 68 codes that you potentially would use. And then as we get down to some of these other things that Veronica's going to talk about, those are other things potentially you'd be billing for in terms of the screens.
Okay, so on the 99368, you guys described the non-physician qualifying health professional. Is that the time that the MA is putting the patient in the room or doing some vitals for you, or what?
No, that's your originating site fee.
Yeah, that's right. That fee will come from the originating site facility fee. I'm going to get clarification on these 99366 through 368 codes, and I will forward that to everybody.
Okay. So we won't be submitting one of these super bills or this form. We won't submit that to you guys. We'll just do that on our side, right, through our billing.
Correct.
Okay.
Okay. Any other questions on that? No? Okay. Just another thing to mention is billing for 2 provider visits in one day. So when the student sees somebody at school-based health center and then on the same day calls in for a telehealth consult, those 2 consults are billable. It just says you each need to use your own individual note for each encounter. And as long as they're different specialties.
So in other words, if they saw the behavioral health person in Lovington and then saw Jane.
Yes.
Working on obesity, overweight, hypertension.
Yes, yes.
Or they saw me and Holly or somebody. Okay.
And they don't necessarily have to be that the behavioral health person specifically thought our consultation was indicated. The behavioral health person could see them for whatever they see them for. They just happen to have a telehealth visit on the same day.
Okay.
They don't have to be linked clinically, right? I didn't think so. I think it was just.
No, I didn't think so either.
I don't think so.
I mean, if you see someone in the clinic, you can see them they can see orthopedics and they can see nephrology for their blood pressure, and near to the twain meet. Each person still gets credit. They just happen to be scheduled on the same day.
Right. Okay. And then there are, the next thing is the 96160 and 96161 codes. Those were new beginning in January, and those are health risk assessment codes. So the 96160 is administration of patient-focused health risk assessment instrument. And the 96161 is administration of caregiver-focused health risk assessment. And so the initial question was, what specialties can these be used for? And can these be used for primary care oral exams? I just came across an article on the web today, and it looks like here it says billing are billable with the following primary codes: outpatient evaluation and management service codes, preventive medicine service codes, codes 96127 and 96110, which are applied per standardized instrument when screening for emotional, behavioral, and developmental status, respectively. And it says many other EM services. So I ran this by our new director who used to work at Presbyterian, and he says that this is probably used for most everything, so long as...
These 2?
Yes, both of them. So long as it's follows. The instrument is standardized, the instrument is scorable, the results are documented in the medical record, and practice expense is incurred to administer the instrument.
So
Such as a
standardized, scorable, and documented.
Yes.
Cool.
Yeah.
Okay.
So, and do we have these on the charge ticket? I haven't even.
We have the 96160 and 161.
Okay.
But those other ones you mentioned, the 96127. I was wondering if we're supposed to use that one. So there's something that in my mind from last year was one of those ones that we weren't supposed to use.
That one says brief emotional behavioral assessment, depression inventory, attention deficit, hyperactivity disorder.
Yeah, I think we don't use that one.
Okay.
I think we've been instructed not to use that one just because I think the reimbursement is.
Okay.
There have been some issues, and that's why I'm so glad you followed up with these other two codes, because those are the ones that we've sort of been directed to, but we wanted to make sure they weren't just limited to behavioral health risk assessment.
Okay.
That you could actually use them for other kinds of risk assessment.
Okay. And
Veronica, we do have a question
Yes.
in chat. How would I bill for both a medical provider and behavioral health provider seeing the patient at the same time?
I'm not sure. Do you? So in the same consult with the patient.
Kevin, read it again.
So the question from Sandra is, how would I bill for both a medical provider and behavioral health provider seeing the patient at the same time?
Okay. The way we do that on our side is it's completely different diagnoses. So as long as they're being seen and treated for different reasons, then that's two different specialties. So you just bill it like your family practice provider would bill their side, their 992 codes, and then the behavioral health specialist would bill their codes. We do that. I don't know how if it would be any different though with this telemedicine.
It sounded like the question was, if you have two providers seeing one person at the same time for the purpose of, clinically thinking that this is a better thing to do to meet jointly at one time, can you bill for that? How do you do it?
Well, it doesn't meet the case code, right? Because it has to be 3 people.
Right. And I don't think it'd be a case consultation because the patient is present. So I wonder if it would be a similar scenario to the patient seeing two providers on the same day, even if it's at the same time. I'm not certain. But I can ask that question of our coding department. Would they be the correct people to ask? Kathy or Cynthia?
Yes, we're sorry, we had it on mute and didn't realize it. Yes, so they would be there. So it'd be Cassandra or Jackie that you would ask.
Okay.
Okay.
Okay. I will figure that out. Okay. Any other questions? Okay. That is all that I had here, but I think, did you have more questions?
So I think you answered a lot. So actually we have an additional option. So I wasn't, the idea that you could actually do a team conference is new. I didn't realize that we had that option. The 3 or more, but that's kind of interesting side. And I think my biggest issue was around those codes. Now the follow-up that I wanted to ask, since we have all the people from medical group, is how do we handle group visits? Because we have codes for groups. And so my understanding of a group visit was that people who are being seen for the same thing, say diabetes education or physical activity nutrition work, carbohydrate counting if we're looking at diabetes management, all of
asthma management with athletics.
Yeah, because we were thinking about, Lovington in particular had an interest in doing some small group asthma education around using the asthma action plan. So what's the path for that in terms of billing? Because my understanding, looking at this, and it's been a few years, is that there had to be some portion of the visit where somebody had some hands-on with them. So in other words, if they went to Lovington and it was, say, children with asthma, and they were going to work on how best to use their asthma action plans, they would have had 5 to 10 minutes with a provider in the school-based health center clinic before they came to the group visit. And then the group visit would require the provider conducting the group visit to write a note in each patient's chart about what was covered in that visit. But my question, I think, to you all at the medical group is, I understand that in a face-to-face setting in a clinic when we're all in the same building, that if I'm going to do a group visit, that I say hi to my patient by themselves for 5 to 10 minutes before they're in the group. What if the hi is by the school-based health center face-to-face people and the group is conducted by our specialists, which is where I think we're going to, what will happen in this setting. Do we also have to have 5 minutes to say hi or some, one-on-one with each of the patients in the group visit before we can do the group visit and use those group visit codes?
This is Elena. That is more of a coding. We'd have to ask Cassandra that. But then I want to understand too, are you talking about like an education class? Are you wanting to build education, like diabetes education,
Yes.
asthma education? Yes?
Yes.
Okay, so that I'm going to have to look up to see. I don't believe we actually bill for education, but I can check on that. And as far as the other question that you were asking, as far as what, do you have to individually say hi, that would be Cassandra when she's coding it to see what the criteria is to code and be billable.
So, we and think more broadly about education. So we tend to put education in sort of a bucket and we think, oh, we're not really providing care because we're supporting somebody's self-management of their disease, which is actually self-management. It's not me talking to you about what you need to do. So if we were to look at this billing code or billing ticket, especially under medical nutrition therapy, so I'm the RD in the group here, and would be providing medical nutrition therapy. But these codes are also applicable to nurse practitioners in our program. They can be used by physicians, nurse practitioners, or dietitians in New Mexico. So I could see in a situation, say with Mesa Vista, they are actively wanting to pursue work with children and families around obesity management, which is one of our core content areas in FRONTERAS. They have a promotora who can potentially work with families, but they at some point are going to need probably some more intense or more focused nutrition therapy. And so that's medical nutrition therapy provided in a group setting. Okay. So it's not really education. We tend to think about it that way, but if you have a provider visit, I mean, you're basically taking what you know about that child given their progress in managing their weight, their height, their blood pressure, and you're actually applying a therapy model, in this case nutrition, to that chronic disease. And so it's not really education. It's really
a group therapy session then.
It's really a group therapy session. And that's basically, and the same would apply to asthma. They're actually working with families and children on management of their asthma using an asthma action plan, which is not education, it's management. Is that?
Yeah, and I guess I was curious that you said that you don't bill for education, that within the realm of providing diabetes care, one of the key requirements is self-management education. So, and I'm hard pressed to believe that people can't bill for that intervention.
The attestation. It's an attestation that you have to sign for diabetes education with like your government payers. Normally you'll have to get a waiver saying that we can bill for those services. So we would need to check with coding on the group therapy end of that.
Okay. I will do that as well.
Okay. Thank you, Veronica.
Sure.
So I think those were my questions. In terms of, did you want to talk about anything that you had questions about?
No, it would be interesting to find out where the options for case conferencing go, because I could see that being a potentially relevant intervention to pull together multiple clinicians, each with a different, and it might not even be their behavior, but it might be their social worker or whoever, to kind of, get everyone on the same page about what options might exist for a kiddo.
Yeah, I think that I didn't even realize we could do that. That's that was great, because that now adds another dimension, to the work that we can do. So, Veronica and your team, do you want to talk anything about how we're going to track this? Because one of the things that we wanted to be able to do, and one of the things that we're asking the school-based health centers to do, is track their success with using these codes. So I know because we're doing our billing within our system, there's going to be a way that you and your team can look at that. Is there anything that we need to think about differently about getting that same information from our school-based health centers? Because we would hate to lead them down the garden path for 6 months and then not be paid for any of these things if we're doing it incorrectly.
That's a good question. We're starting at the Center for Telehealth now. I'm going to get access to the Anodyne system, so I'll be able to run reports. And we are starting to look at that more carefully now with our new director. That's one of his main initiatives, is this telehealth revenue cycle, which is great for FRONTERAS because we're going to be looking at that probably monthly.
Okay, yes.
And just really tracking things, seeing how they're being reimbursed, what's working, what isn't working, what's falling into the non-billable. We'll see what happens there. And maybe as I go through that, I can start thinking about what the school-based health centers need to track. So they're going to have the facility fees, the consultation fees, possibly those group consultation fees. So maybe I can sort of guide them as to what reports they'll need to query and how to follow up on the reimbursements. Is that primarily what you're talking about, is the reimbursements? Okay.
Right, reimbursement. Because, one of the things that when we, wrote the grant, one of the things that was really important to us was making this sustainable. When we've talked to some of the other grantees under this particular HRSA RFA, they're paying for stuff out of the grant. So they're paying for their providers out of the grant. And we're doing that too. But the idea is after 3 years, if we haven't figured out how to make this financially sustainable through reimbursement, it's all going to go away and we won't be able to continue it. So that part's really, really important.
Okay. And another thing I should mention is the school-based health centers should remember to use the telehealth modifiers, which the video conferencing is it's 9.5. It was just updated. It's 9.5, though I believe it's Medicaid that still uses GT. But the information that I gather from the coding department, I'll also add the modifier information for the school-based health center. So just make sure you add those modifiers for all of the billing for FRONTERAS.
So I'm thinking that potentially what we need from your team is we need a one-page instruction sheet for the school-based health centers on how to use these, because it's one thing for us to use our code where you've already put the 9.5 modifier in here. If we just check the box, we're good. But if they forget to do that on that end, so if you guys could come up with like a one-pager that we could share with the school-based health centers about all of these things that we've talked about, just clarification. I think that would be really, really helpful.
That makes sense.
Okay, for our charge entry step, we already have an edit in place. So if they enter anything for telehealth, it automatically prompts them for the modifiers.
Yes. Yeah, and that's part of that location, the 73 telehealth, or it's actually point of service 02. The TES edits are built in there to make sure that the modifiers are attached. But I also have it on here as an overkill, I guess. I don't know. Maybe it's a reminder.
Overkill is good. Yeah. I think that the issue will be on our school-based health center side because they haven't done this before. So making sure that they've got that to share with their billing folks. And, Tammy's here, but she's also got coders and billers on her side. And all of our other sites have coders and billers because of the FQHC, environment. That provider is just doing whatever they're doing normally. They're not necessarily following that up.
Okay. And were there any other questions that came up?
We don't have anything on our side.
Maya, was there anything that maybe I left out? I missed a couple calls because of travel last week, but is there anything new that came up?
No, nothing new. We were just anticipating this training.
Okay. All right. Well, thanks
So
all.
will we be having
Thank
an,
you.
Thank you.
Thank you.
Thank you. Have a good day.
Too. Bye-bye.
What did she?
Did somebody have a question?
Tammy, did you have a question?
yeah, will we be having another call once this is all updated and you've confirmed the different codes and some of the questions that have come up, or?
We can cover those on our coaching calls.
Okay,
So Veronica's really fast, and so I know she's going to get the stuff together really quickly. And then you'll get that communication from Maya, and then we'll just cover it in our usual coaching calls.
okay, that sounds good.
All right, thank you.
Thank you.
Thank you.